Rheumatoid arthritis is similar to most chronic conditions in the sense that there is an algorithm, and again, going back to the ACR guidelines that clearly identify that starts with more conservative, less invasive or expensive treatments, if you will, and goes stepwise to the ones that are more intense, have hopefully greater efficacy, but also carry likely higher rates of potential adverse events and, of course, higher costs. Our guidelines, which are very similar to those you see across the managed care sector, urge physicians to start with the lower cost, simpler, if you will, interventions up to and including methotrexate. When we get requests for a drug like a TNF, like say Humira or Enbrel, we would hope to find that there has been a meaningful trial of a drug like methotrexate for say 3 to 6 months to establish that in fact the patient has not responded, or at least not responded to the optimal level. At that point, it's a lot easier for the role of a drug like a Humira or an Enbrel or even a Remicade to be identified and to say that yes, that's the next logical step in the treatment pattern. Well, one option for treating severe rheumatoid arthritis is subcutaneous methotrexate. Typically that is for patients who have severe RA and have failed to respond to generic methotrexate. We don't see a lot of that because I think of the efficacy and the very high level of tolerability of the TNFs, Remicade, Enbrel, Humira. Certainly sub-Q methotrexate is an option. We do allow it if the member meets the criteria as I've outlined it. However, I think the trend seems to be more towards the TNFs. In fact, this is a trend that's been going on for some years, and even as more orals come out, I think that will supplant a lot of the parenteral treatments as well. Subcutaneous methotrexate is typically covered for severe rheumatoid arthritis, usually in a scenario where the patient has failed to respond, or at least not responded to the level that either the patient or clinician would expect, to something like an oral methotrexate. It has a prior authorization, and that's typically required not so much for cost, but mainly because of the potential for adverse events, and also because the sub-Q version of methotrexate is indicated primarily for severe RA as opposed to mild or moderate or as a first-line treatment. Certainly what's driven rheumatoid arthritis into the top 10 or at most top 15 category in terms of drug costs nationally has been the advent of the TNFs, Humira, Enbrel, Remicade. That really has revolutionized treatment of rheumatoid arthritis over the last 15 plus years. We cover those drugs that are universally covered for rheumatoid arthritis. There is universally prior authorization. Typically that prior authorization reflects, as I've said earlier, the expectation that patients will start with the less intense treatments and build their way up to something like a TNF. We do want to see at least a meaningful trial of something like oral methotrexate, usually in the 3 to 6 month range, but certainly if the clinician feels that the level of improvement has been suboptimal, that's an appropriate time to request a drug like a TNF. Combination treatment in rheumatoid arthritis, and combination treatment being defined as, say, methotrexate plus a TNF, has been around for a long time. Certainly one of the strategies that many rheumatologists use is to layer the TNF on top of the methotrexate as opposed to stopping the methotrexate or NSAIDs and then moving solely to monotherapy with the TNF. The appropriateness of that is probably going to depend on each individual clinical situation, and our plan, as do many plans, will defer to the recommendation of the clinician as to whether or not the combination of methotrexate plus a TNF is most appropriate versus the TNF alone. Regardless, ideally we're only talking about the use of a biologic like a TNF if the prior treatment with a methotrexate has not reached the clinical endpoints that the physician was hoping for. Biologics are frequently used in rheumatoid arthritis, and that's certainly the main driver for rheumatoid arthritis being a high-cost area today, despite the fact that it is not as common as conditions like diabetes, for example. Biologics are typically viewed as second-line treatments, i.e. after a meaningful course of methotrexate. Are there conditions when, or situations when we would approve biologic as a first-line therapy? Potentially. I'm thinking perhaps of a situation where you had a brand new diagnosis of rheumatoid arthritis with significant joint pain and anatomical distortion, and clearly a patient whose condition was progressing very rapidly, and if the clinician did not feel that this patient had the time to start on a course of methotrexate, moving straight to TNF might be appropriate. However, I think the default, both clinically as well as from the managed care perspective, is that we'll see that progression from the less intense therapy to the more intense in order to give each line of therapy an opportunity to work.